Hello, everybody. I want to welcome you all to Pediatric Grand Rounds, both the people that are here live in our auditorium and then as well as people on Zoom. And again, I just want to remind everybody, Sandrain is not with us today, but she is hoping to encourage as many people as possible to come and participate live. So we hope to see as many of you as possible here. And I will turn it over to Deb Franzen to introduce our speakers for today.
Thanks, Rafi. Good afternoon. For those of you who may not know me, I'm Deb Franzen. I'm our Executive Medical Director for Quality and Safety for the Children's Hospitals. And I'm thrilled to introduce our guest speakers today for Grand Rounds. Wanted to do a brief introduction of each of them. Maud Dole is one of our critical care faculty that works in the transitional care unit, is the medical director there. She graduated from Albany Medical College and completed a combined internal medicine and pediatric residency and pediatric critical care fellowship in Buffalo, New York. She has a master's degree in patient safety leadership from the University of Chicago, and she joined us here at UCSF in 2018 and is really focused on providing high quality care and resident education. If you haven't noticed her around, she rides her bike a lot, meaning every day to and from the hospital. She's really passionate about providing exceptional care, even for sort of the most straightforward of diagnoses, and you'll hear more about that in our lecture. And according to Maud, it takes focus and commitment to do common care uncommonly well. So I thought that was well said. Our second speaker is Mandeep Chada. He's a pediatric intensivist in our division and works primarily at Oakland Children's Hospital. He trained in critical care at Pittsburgh and has additional expertise and training in pediatric neurointensive care, resuscitation, and pediatric cardiovascular intensive care. He also serves as the medical director for respiratory care services there, and as well as the section lead for quality improvement at Oakland. Personally, in my role, I've had the great pleasure to work with both of them on important initiatives. Maud has been a great support in our CLABSI prevention efforts, and in earlier this year in 2022, she took that on as the lead and is really making great strides. And Mandeep has been my co-pilot for our Caring Wisely, UCSF-funded Caring Wisely project to reduce delirium across the Bay. So I'm thrilled to have them here to share their work in the AAP Value in Inpatient Pediatrics Network multi-site collaborative to try to reduce unnecessary use of high flow. So I'll turn it over to our speakers. Please join me in welcoming them.
Good afternoon. Thanks, Deb, for the wonderful introduction, and thank you all for the invitation to come and join you and share this really wonderful work. We don't have any pertinent disclosures. I wanted to start with a recognition of the team leaders on both campuses who were instrumental in making this project happen. We're fortunate in having a really diverse, experienced, multidisciplinary committee that has been dealing with the utilization of high flow in our hospitals for some time, and a lot of special thanks to Heather Esparza, Sarah Koo, and Dane Geringer, some of my partners at Oakland, who contributed significantly to some of the information you're going to see here in the slides that we're going to share with you. So the objectives for today, we're going to describe the pathophysiology and clinical characteristics of children with bronchiolitis. We're going to list evidence-based therapies used in the management of children admitted with bronchiolitis and acute respiratory failure. And we're going to describe how a collaborative quality improvement methodology can be used to address overuse of heated high-flow nasal cannula therapy for bronchiolitis and reduce length of stay and costs across 2 affiliated campuses. And it's worth noting that many of the people who are involved in this project, while having considerable expertise in their own right and domains, this was for many their first experience with a really large quality improvement project. And I think it speaks to the really excellent support and mentorship we had from a lot of people, including the quality and safety team, our own divisions and leaders, and Deb in particular. So it would be useful to start with a definition of bronchiolitis, and that's sometimes a little challenging because when we're talking about pediatric bronchiolitis, we're frequently talking about a pattern of disease. And there's not a tremendous amount of consistency in the international diagnostic criteria that are used, but a few common things that most experts agree on is that bronchiolitis it's represented by the first or second episode of respiratory illness in infants or young children associated with a viral respiratory illness, and that there are typically symptoms of lower respiratory tract involvement like wheezing or crackles. And the difficulties in defining this entity don't stop there. There are pretty considerable age-related differences in the severity of the disease and the symptoms that we see in the response to treatment and the progression of the disease over time. There are clearly different molecular immune signatures. There are differences among the various causative viruses, and there is an increasing recognition of a continuum of this acute illness with chronic respiratory conditions and atopic disease. So I'll start with a question. Bronchiolitis is an infection of the respiratory tract characterized by which of the following? Rhinorrhea, wheezing, hypoxemia, tachypnea, or all of the above? And hopefully you have an answer in your mind. And for most pediatricians, clearly it's all of the above, right? We see all of these manifestations in this broad entity called bronchiolitis. And so here's a kind of a scheme of the pathophysiology of this disease. And you'll see in the upper left a picture of a healthy bronchiole and wonderful patent lumen and healthy tissue and vasculature and nicely patent alveoli participating in gas exchange. And then you'll see below that a picture in bronchiolitis, and you can see there's significant derangement, and there's edema and thickening of the tissues. There's obstruction of the airway with debris and mucus and other things, and collapse of alveoli, for example. And when you go through kind of the pathophysiologic process, you can see not only the spread of infection from the upper to the lower airways, the sloughing of epithelial cells, the intraluminal obstruction that occurs as a result of all this new debris, the air trapping that results, and ultimately the loss of alveolar space and abnormal gas exchange. And reflected in this scheme is all the classic symptoms of bronchiolitis that we recognize: rhinorrhea, fever, and other signs of inflammation, wheezing, and crackles. And here are the primary players in this process. You can see respiratory syncytial virus, or RSV, accounts for probably the majority of bronchiolitis historically, but almost every other virus that we see routinely in pediatrics has been implicated in a clinical phenotype of bronchiolitis. And I'll note here too that while coronavirus has been well known to be associated with bronchiolitis, COVID-19 in particular, I don't think we necessarily saw a very impressive presentation of classic bronchiolitis in children early in the pandemic. I think we're starting to see more of that now, but certainly we've seen other significant complications from that disease. And as we learn more about the molecular immunology of these viruses and how they interact with the host immune response, I think there's an improving recognition of this association between viral infection and atopic disease, especially with viruses like RSV. And in particular, I'll highlight the dysregulation of the immune system that's been demonstrated in a number of manners that leads ultimately to basophilic and eosinophilic activation and an abundance of IgE production. And I think what's not clear yet is whether these patients who go on to have this continuum have a genetic predisposition to this pathophysiologic process, or whether there's actually a modification of the immune system or respiratory function by the viruses, or some combination of the two. We know that bronchiolitis is bread and butter pediatrics. We see a lot of it, and it's pretty high impact. There's data that suggests, and this is from a survey from some years ago, estimated 150,000 patients hospitalized with bronchiolitis. And the frequency of these hospitalizations was higher in children less than 1 year of age. And in fact, it's the leading cause of hospitalization in this age group, male gender, and interestingly, in non-white race. Mean length of stay was about 3.3 days in this survey, which will be important when we talk about our data. And the costs are substantial. And I would imagine that the costs are considerably more now in the current economic condition, but with simple bronchiolitis, but it can increase dramatically with comorbid conditions, including the diagnosis of pneumonia. So again, bread and butter pediatrics, we've all seen patients like this, an ill-appearing child with significant intercostal and subcostal and suprasternal retractions, tachypnea, and you don't see the monitor here. There's some hypoxemia, and if the sound were on, you would hear some wheezing and some hoarse breath sounds. We've all seen patients like this, and it's a presentation that tends to get our attention. So what's the treatment? Unfortunately, largely we rely on supportive measures for the treatment of bronchiolitis. And so we do a number of things to improve oxygen delivery, and we'll talk a lot more about that. We can do lots of other things that can support good gas exchange and balance in the patient, including reducing metabolic demands by the use of antipyretics, airway positioning and clearance. So suctioning is a really important part of the management of this disease, and good hydration and nutritional support, which is frequently one of the primary indications for needing to admit these patients. And then ultimately, we may need to move on to more robust forms of improving oxygen delivery and gas exchange. And of course, we should be thinking always about treating comorbid conditions, including perhaps the treatment of community-acquired bacterial pneumonia. So another question. Evidence-based therapies for the initial management of previously healthy children admitted with uncomplicated bronchiolitis include low-flow oxygen delivery, high-flow oxygen delivery, nebulized albuterol, steroids, nebulized hypertonic saline. If you have your answer in your mind, the only evidence-based strategy that is listed here for bronchiolitis for initial management is low-flow oxygen delivery. Now, we're fortunate that we do have some consensus guidelines for the management of bronchiolitis, and these were initially released in 2006 and were updated in 2016. And in this summary in the New England Journal, I'll highlight here, again, only really 2 primary therapies have some evidence basis for management of this disease: supplemental oxygen and nutrition and hydration. And it's fair to say that these consensus guidelines were not met with unanimous happiness. And in fact, there were accusations of the AAP taking an overly nihilistic approach in the management of bronchiolitis. And in particular, I think for first-line providers, including our colleagues, for example, in the emergency room, where you're presented with a phenotype of patient and it may not be absolutely clear what the underlying pathophysiology is for that patient on that continuum that I referred to. The suggestion, for example, that you wouldn't do a trial of bronchodilators, I think many people found rather insulting. But we do have some evidence that following the guidelines and avoiding the use of some of these poorly supported therapies does pay some dividends. And here's some data from a paper, and this included both information about ED patients and inpatients, and I'll focus on the inpatient stuff. But in general, with the initiation and update of the guidelines, we did see an acceleration of the reduction in use of these non-supported therapies without apparent impact on outcomes. So some motivation to avoid using not evidence-based therapies, but the debate goes on. And this actually is a recent paper that came out suggesting that perhaps there is some benefit in a trial of corticosteroids and inhaled racemic epinephrine for bronchiolitis. Lots of issues with that paper, which I won't discuss here, but I think this is something we'll continue to see in the literature. Now, I'm an intensivist, so I can't not talk a little bit about the meaning of life. Some of my colleagues here who've heard various things from me know that this is a frequent way I begin. And I think for lots of what we do in medicine, a lot of what we do, including especially in the ICU, is trying to balance oxygen delivery and oxygen consumption. And it's important to use the words respiratory failure. And I think we have to really kind of get away from this idea that only when the patient is blue and intubated and on the ventilator or the oscillator or the ICU, that they're in respiratory failure. We see this all the time in the clinics, in the emergency room. Respiratory failure occurs when respiratory system dysfunction leads to inadequate gas exchange. We have plenty of patients who come in with completely run-of-the-mill bronchiolitis who are quite hypoxemic and tachypnic and distressed, and we can classify those patients as having respiratory failure. And we have in various places, general kind of strategies or algorithms that we use in the management of acute respiratory failure. And this is an example of kind of a scheme that we use in Oakland very frequently. And so you can see some of the major players here down the middle, right up to VV ECMO. But let's focus on the early stages of this process. And it's good to remind everyone here kind of the simple strategies of oxygen supplementation that most of us are familiar with. You've seen on the left a simple nasal cannula or a simple face mask. In the middle with the multicolored modules there, a Venturi mask that may allow you to slightly better titrate the amount of oxygen being delivered. You can see a non-rebreather or a hood, which we think is at least non-invasively the simplest and easiest way to actually provide the maximum amount of oxygen delivery. And if you'll skip down a little bit to this kind of broad category of non-invasive ventilation or classic conventional ventilation in an intubated patient, you can see a number of different interfaces, including RAM cannulas and nasal CPAP or facial BiPAP. And you see a NAVA catheter there on the right. And in general, I'll highlight the fact that in most of these modalities, an actual physical ventilator is required to do more than just simple flow of oxygen. And then we come to the middle, heated high flow nasal cannula. And this is a picture that shows kind of the various the progression of the generations of the product that is primarily used in both of our hospitals, the high flow cannula. And what you'll notice if you look carefully is that as this product evolves, it begins to incorporate aspects of some of the other more sophisticated interfaces that we use so that you can actually increase and optimize the delivery of flow to the patient. So a little bit of history about high flow. Since the dawn of giving gas to any patient in any form, you can imagine that if someone gave some oxygen and thought that was helpful to a patient, someone else came up with an even better idea that more is going to help the patient. And what we discovered very quickly is that very high flow rates of compressed air or oxygen can have some really deleterious side effects: desiccation of mucosa, impairment of mucociliary function, thickening of secretions, none of which we'd like to see in a patient with bronchiolitis. And that can also lead to increased inflammation and increased caloric expenditure and insensible losses. This will really affect the ability of the patient, for example, to regulate their own body temperature. Oddly enough, the first utilization of high flow actually became in racehorses. As most of you know, like infants, racehorses are obligate nose breathers. And they are particularly susceptible, it turns out, to the occurrence of pulmonary hemorrhage when they exert themselves. And so, a clever group of people came up with a strategy to actually deliver very high flow rates of humidified oxygen to racehorses to precondition them prior to their race so that they would have a lower incidence of pulmonary hemorrhage and it would actually improve their performance. And we're talking about pretty substantial flow rates here, like 300 to 400 liters per minute of humidified flow. So mechanically, this is really a trick. And we've had our ups and downs in the application of this technology in human patients as well. And some of you who've been around for a long time will remember back in the days of Vapotherm, which is one of the commercial products that's available, which was actually taken off the market due to the occurrence of really unusual respiratory pathogens appearing in patients. So there was a period of time where commercial products were not available, and many hospitals actually developed their own kind of rigs to deliver heated high flow nasal cannula, and they follow kind of this general kind of model that you see on the left, right? There's flow with a blender like you're accustomed to seeing in the hospital, and that leads into a unit that actually humidifies and heats the gas, and you can see the bag of saline there, or water that is used to humidify it, and then that leads to a circuit that then is able to deliver this high flow to the patient. And we now have a really nice array of devices that can cover a pretty broad spectrum of patient sizes. And you can see over to the right, kind of the rough range of weights and flow rates that we can see. And one of the really important innovations that's happened in high flow with these progressive generations of products is the ability to more effectively deliver higher flow rates to the patient without some of the common problems that we experience, like rain out of condensation, which could really be substantial. You'd have to suction a lot of water, for example, from patients' noses and mouths, and back pressure that might develop when you're hitting the significant resistor of a snotty nose. And you can see that this goes right up into the adult size, and we have devices that actually allow us to deliver flow rates of up to 50 to 80 liters per minute. And there's a really significant change in recent history in our understanding of what high flow does and how effective it may be. And I think you have practitioners on both sides of the continuum. On one side, thinking high flow probably doesn't do any of the things that have been speculated to do, and then others who think it maybe probably overestimate its ability to support patients. But we have a lot of evidence that suggests that just simply the heated and humidification of gas can improve mucociliary function and improve secretion clearance. There's some degree of washout that you can see in the graphic on the upper right of the upper airways. And with that washout of the dead space that is normally not involved in gas exchange, we probably do achieve some considerable amount of CO2 clearance and improved oxygen delivery. The high flow rates have been speculated for a long time to actually be able to provide some improved aeration of the lungs, or PEEP. And anyone who's watched a patient on high flow with a gaping wide mouth, which is how most of our children look, could reasonably be very skeptical of this claim of PEEP. But there is some evidence, and you can see some of the scintigraphic evidence that I showed here on the lower right, that in patients, especially larger patients who are able to be cooperative and close their mouth, that they can actually have some significantly improved aeration of their lower respiratory tract. And then just the fact that you're able to prevent the patient from imbibing a lot of ambient air in their mouth because the flow rate is so high probably also just improves oxygen delivery. Here's an example of kind of a general scheme. This is the protocol from Oakland's acute care units about how we use high flow. And I'll emphasize a couple of things about this algorithm. While there might be a modest starting range, at a point where it's thought the patient needs more support, we generally now use a weight-based algorithm, which we're hoping to eventually adapt here for the use in Mission Bay. And I'll particularly highlight the weaning pathway. We do have a protocol in place in Oakland prior to this project to wean flow, and it was pretty slow and very dependent on the practitioners advancing the steps of the weaning protocol, and I think it'll help explain some of the data that we'll show you later. So in Oakland in particular, we did have over some years an expansion to alternate indications beyond bronchiolitis. While it was initially used exclusively in the pediatric ICU, which is a more common practice in many hospitals, we did ultimately expand our practice to the wards and to the ED, and we developed customized protocols for use in those places. And I think in doing this, I think our hope was that patients with of relatively lower acuity could be effectively managed, and we would reduce the necessity of admitting those patients to the ICU, or reduce the necessity of transferring them later to the ICU, or even ultimately have to undergo intubation. And so with these increased flow rates and weight-based algorithms, there was actually a very nice quality improvement project that one of our chief residents did some years ago at the time that we were going through this transition. And I'll highlight here that we largely achieved what we thought, which is that you can see in the area in the green on the top row that the number of patients that needed to be admitted from the emergency room to the PICU for high flow reduced over time, and also the number of patients in orange below that needed to be escalated to the ICU reduced over time. So just briefly, what's the evidence what's the summary of the evidence for high flow? We had a lot of initial single center observational studies which suggested improved outcomes, and that really drove use substantially over the last decade. But over time, these initial findings have not really held true. And we now have a number of large prospective randomized trials of high flow and bronchiolitis over the last few years. And I've kind of combined several studies here, a large number of patients with mild to moderate bronchiolitis that are randomized to either high flow or standalone nasal cannula. And of course, among these studies, there's a lot of variability in initiation and weaning practices. I think what's striking, though, is that nearly 70% of patients who are randomized to low flow nasal cannula did not require escalation therapy. And there ultimately didn't seem to be any difference between groups in terms of how often they needed to go to the ICU and get intubated, how long they stayed in the hospital, or the duration of oxygen therapy overall. And these factors probably contribute to the fact that we see a lot of increased medical costs associated with the use of high flow. What's also interesting recently, and this is something that's pretty familiar to most of us in the pediatric ICU, is that rapid discontinuation of high flow has been shown to be pretty safe, both in the ICU and in the ward setting. And I think, again, getting back to that point of how much support are you really giving your patient, there could be some reasonable anxiety about rapidly taking that support away. But what we find is that you can do that, and you can decrease the duration of high flow and decrease the length of stay with little to no adverse events or need for escalation of care. So final question, rapid discontinuation of heated high flow nasal cannula therapy for bronchiolitis may result in successful weaning, intubation, reduced length of stay, or a MedStat or a code blue? Or is it successful weaning and reduced length of stay? These are gimmies, I hope. But I've convinced you, I think, that while high flow may have a role in the management of respiratory failure in patients with bronchiolitis, we probably use it a little too much, and we can probably wean it more rapidly than we do without ill effect. And I'll hand it over to Maud.
Thank you. So high flow nasal cannula in the setting of bronchiolitis has actually gone through a life cycle that those of us with gray hair may have seen for other treatments for bronchiolitis, specifically that you will see a new therapy that'll come up. Everyone will go, this is it. This is the treatment. And they'll get very excited. We get on board. We start giving the patients the therapy, and we're convinced it works. And as more studies come out, those underpinnings of our being convinced start getting pulled out from under us. And the therapy starts to fade. And the problem is that it doesn't really fade away in the same way that it came on. A lot of times it's very hard. The final phase of using a therapy is that you kind of have to let it go. And it's really hard to do that. High flow, I think, is really particularly challenging with this. We know that when it comes to treating patients with mild and moderate bronchiolitis, that the thrill is gone. But I think it's very hard when we look at infants, like the one in the video, who are really struggling to breathe, for us to do less and not be able to sort of do something. And so sometimes it's like, don't do something, just stand there, is very hard to do in this population. And so I think a lot of times we wonder, what is the harm to using high flow in the bronchiolitis population? And there is a paper that came out last year that's very interesting. It's from the PIRN network. Now, this is in Canada. And it looks at bronchiolitis inpatient, outpatient over almost a 14-year period that happens to coincide with my career in pediatrics. And they looked at children less than the age of 2 with a diagnosis of bronchiolitis, inpatient and outpatient. And over that whole period, there was no evidence that bronchiolitis was worse, in that they were not admitting more patients with bronchiolitis, and the mortality rate for bronchiolitis stayed stable, and I would add very low. But ICU admission has been increasing significantly, and the cost of care for patients with bronchiolitis has been increasing significantly over this period of time. And so we've seen this intensification of the management of a condition that is really bread and butter pediatrics, and we all, well, except the pandemic people, that we've all been managing for years and years. And so the questions that came up when we started seeing this data, and this data also reflects from the United States, is, are these patients really sicker? And there really isn't strong evidence. It's not like we have these cadres of NICU graduates that are now worse with bronchiolitis and end up in ICUs. The patients do not appear sicker overall based on mortality and admission rates. So it's not that. And are there less sick patients on the wards? And this could be an argument. Like, we've also during this period of time become very good through Pew's system, early warning system, rapid response systems, of identifying patients that are at risk for respiratory failure and transferring them early. So some of these bronchiolitis patients are probably going to the ICU appropriately earlier and not getting into trouble on the floor. So we see less code whites on the floor and more bronchiolitis patients in the ICUs. In the ICUs. So there is probably an element of that. But there's also a question that we have is high flow nasal cannula playing a role in this phenomenon of the intensification of the management of inpatient bronchiolitis? And I think there is an element of this as well. I can't prove it yet. And the idea here is that a lot of hospitals, including Oakland and San Francisco, have flow limitations. So if I have an infant that's on 8 liters of high flow nasal cannula, no matter how good or bad he or she looks, that patient is very likely to get transferred to the ICU because of policy and because of what we perceive with what high flow is. And when those patients get transferred, they're more likely to be ending up on CPAP or higher levels of therapy, because bronchiolitis is a highly variable disease. So the child will look terrible, and then if you wait a little while, they look better, but you feel like you have to do something. So we think that there's this intensification phenomenon going on. So this leads to a lot of disquiet around the use of high flow nasal cannula in the management of bronchiolitis. We use it for all these indications, certainly bronchiolitis. And we are seeing like length of stay and utilization going way up, particularly in places that are really good at using using high flow nasal cannula, like our partners in Oakland, but also here in San Francisco. And we've really been, up till now, not able to really accurately track our rates of use and diagnoses that we're using it for. So along came the American Academy of Pediatrics, our friends, and they had, in the middle of the pandemic, came out with the high flow interventions to facilitate less overuse. And this program, which is the Value in Inpatient Pediatrics, I can't recommend it enough to you. If you have the opportunity to participate in one of these, go for it, because they really provided us a great deal of support in able to initiate a multi-center project. And so they gave us a timetable, educational materials. They gave us QI essentials, training. I mean, and really it's like just a great way to learn how to do this kind of work in a very supportive environment. And basically what we did was we were going to look at our baseline, which was just pre-pandemic, and an intervention period that was in 11-21 to 22, and see if we could just get the high flow rates and how much we were using to come down. So in order to do this, we decided rather ambitiously that we were going to do this as a cross-Bay team. So we wanted to do this with Oakland and like do something together. And so the first thing is we really actually had to learn about each other as individuals, hospitals, and teams. So we were able to make strong relationships and sort of begin to start working with each other in ways that were much more productive than we had the opportunity to do before on Zoom during a pandemic. And we were able to coordinate basically 2 separate teams together. We ended up deciding to do 2 different centers with the AAP because of some of the way that data flows in the different hospitals, and also because of some pretty big differences that I'll get to in a minute. And in order to do that, we also did our IRB waiver process together, which was an adventure. So let's talk about our cross-Bay differences a little bit, because I think it's really instructive when we're working together to try to unify and coordinate a quality improvement project, as you really need to understand how things work in both hospitals. So Oakland actually does high flow nasal cannula all over the place, whereas here we only do it in ICUs and transitional care units. Oakland has a very robust multidisciplinary respiratory committee and clinical sort of governance system around respiratory therapies, whereas we don't really have that many protocols. Their notes that the respiratory therapists write are written in Apex, like an actual progress note. Whereas on our side, all of our respiratory therapists just enter things into a flow sheet, which is just a different way of documenting. And because of that, they had a really good existing report system, whereas we had no existing reports. And also Oakland has a different population. So they see more uncomplicated bronchiolitic patients, and we see a little bit less. So we already knew that there were going to be sort of different tools that were going to be necessary on different sides of the bay. But we did have a shared goal, and we decided on a shared strategy. So the AAP offered us two sort of arms that we could do in this project. The first was called the HIP. They have great names, right? And so this was an initiation pause. So like in the emergency room or on the floor, if you think an infant needs to go on high flow nasal cannula, you were supposed to don't do something, just stand there and wait for 15 to 30 minutes, which like just made my palms itch when I thought about it. And then readdress, because we know with bronchiolitis, if you do suctioning, if you do fever management, if you make sure they're hydrated and calm and get everything else under control, often their respiratory status looks better, whether you put them on high flow or not. What we chose was a weaning arm, because we had all known that on both sides, we had a lot of challenges with getting patients off high flow. Anyone who's here that's had the pleasure of rounding with me in the winter would see me have a mini meltdown when a patient hadn't had any weaning overnight because they looked a little bad. So we chose the weaning arm for this. And in honor of our Dr. Franzen here, we did set a smart aim, and across the bay, both sides, we really had the same drivers when it came to why we had trouble getting kids off of high flow quickly. And these included mostly just like, we don't know when to wean, we don't know how to wean, and we're afraid to wean too quickly. And this led us to, again, when we did our holiday, we actually set a very specific aim, and this was set with the AAP. So our plan was to decrease high flow duration and treatment by 30%. That seemed like a lot when we started. We were like, whoa, that's going to be a lot. And in the PICU and the ward. So the primary outcome was just how many hours of treatment in high flow does a patient have? The process would be what percentage of infants with simple, uncomplicated bronchiolitis get a single holiday, just one, during their admission. And our balancing was going to be to look at inpatient length of stay, and of course, look for evidence of any kind of unplanned escalation or of care within an hour of the holiday attempt. So we chose a patient. The patient population was set by the AAP. And it's pretty standard for what you would expect with the bronchiolitis literature, but they had a lot of exclusion criteria, particularly challenging on our side of the bay was that they excluded anyone with a G tube, which knocked out like half of the TCU. And then anyone that was, as I like to say, touched by CPAP or BiPAP when they went to the PICU was also excluded. And the final exclusion that was a little bit challenging, we still did some holidays on these kids, but we couldn't count them, was that if high flow is initiated at an outside facility. So if high flow gets started before transfer, then they couldn't be counted in this process. And so what is this holiday? So I'll kind of walk through it. I'm checking my time here and give you an idea. So basically we do a readiness assessment. Is the kid stable on a minimum FiO2 on high flow nasal cannula? And if they are, we go into a holiday. And so the holiday, just all we ask is that the respiratory therapist remove the nasal cannula from the patient and watch them. So what we would do is call this a spontaneous breathing trial for those of us who work in critical care. And if the patient does well, they go to room air, we just continue our bronchiolitis care and are very likely to discharge them a bit earlier. If they become hypoxemic, we would put them on low flow nasal cannula. And if they deteriorated within 30 minutes of this whole process, we would put them back on the high flow, wait 12 hours and try it again. So it's a pretty simple holiday. And we were able to implement that on both sides of the bay. So Oakland was able to do this in their multiple units. They had the respiratory therapists, intensivists, and hospitalists, as well as nursing, sort of supporting and moving this along. And they also had really good buy-in with the pediatric residents. I'm very jealous because the residents did a lot of their data mining for them. And in Oakland, they were also able to use smart phrases, which allowed them to track the holiday outcomes very clearly and succinctly through the use of their databases and reports. San Francisco, you might be surprised to know, was like a little bit less technologically slick with this. And we just basically used a holiday sheet and filled it out. And then yours truly went through the data and looked up every bronchiolitic patient admitted during both times and just crunched it. So I wouldn't recommend that in the future. So on both sides, we were able to perform real chart reviews. We were able to identify patients that would qualify for the holiday, and we were able to implement these as appropriate. And using PDSA cycles, we were able to really sort of find ways to sort of identify where we needed to fine tune or change our processes to make sure that we had good penetration of this process. And I'm just going to give you an example. So this is from the AAP database. And so the red line is the total AAP, the VIP group, like all of the different centers. And the blue line is Oakland. And you can see like they knocked it out of the park to begin with and then had a little bit of a drop down. Part of that was because I don't know if you remember, but in the middle of this, we actually had a very low rate of admissions for bronchiolitic patients because we filled up with everything else. And then they were able to get it back up. And so by checking their rates every 2 weeks, they were able to identify and correct any times when their numbers were starting to drop. So nationally, they had 86 sites that enrolled. And considering that this was during pandemic times, I think this is pretty good. 79 sites submitted data, and 74 sites were able to submit baseline data. And then we got to 60 sites that I think completed through all the intervention data. So they had about 9,500 patients in the baseline and 4,200 in the study period. And Mandeep's going to go through our local results, and then we'll kind of open up for questions or go further.
So in the interest of time, and fortunately, the data is short but sweet. So here's Oakland. And so this is total hours of high flow use. And you can see our baseline data, which is significant in that we were substantially above the national average. And again, I think we've kind of alluded to some of the factors for this. I think in Oakland, especially, again, uncharacteristic of a lot of children's hospitals, we do heated high flow outside of the ICU. So in areas like the wards where there's much less staffing and much less comfort in moving patients along pretty quickly, I think it's pretty significant factor here. And so we were quite above average. And after the implementation, you can see we really had a really nice response. And so now our goal was to reduce by 30% or down to 55 hours. And we went down to an average of about 41 hours. So we cut our hours of high flow down by half. And in San Francisco, again, you can see we're limited by much fewer numbers for uncomplicated bronchiolitis, right? That's really the key. But again, we saw a very similar decrease in our total hours of use by 27%. And then this is the inpatient length of stay. This is for all of the eligible patients with bronchiolitis, whether they're high flow or not. And you can see here, again, the baseline data. Again, we're a little bit above average for all the reasons we discussed. And after the implementation, we were at along with our other peer institutions, we were able to reduce our overall length of stay by an entire day. And again, in San Francisco, again, limited by the small numbers of patients, but we saw a similar decrease and we were able to reduce the length of stay by at least a shift. So really, really interesting. This is the national data, just to summarize. Overall, the overall project did achieve the specific aim of 30% reduction of high flow hours and a 14-hour reduction in the length of stay. And almost no clinical deterioration. I'm happy to report that in San Francisco and Oakland, we had no clinical deteriorations at all. And I'll just highlight here that they had also really a very nice impact from the people who participated in the initiation study, which may be coming soon to hospital near you. Challenges and lessons. Again, Maud spoke a little bit about this. Change is hard, and there's really good evidence that that when you're trying to do less, change is probably even a little harder. And so we did this across a really a dramatically different kind of unit in different areas with different staffing and experience. A lot of our data tools, while we did have a few data tools in Oakland, were really not providing us the information we needed about our patients with bronchiolitis. And as you guys know, getting anything changed in the EMR takes a lot of time. And she's talked a lot about the cross-bay differences, which I won't perseverate on, but I will say, and it's worth mentioning again, that having the results that we had with this project in the course of both the pandemic and the kind of ongoing growing pains of our affiliation between our two campuses, I think is really a remarkable testament to the teamwork that happened, not only among the individual teams, but also between the two teams across the Bay. And I think we really is a great example of how we were much stronger and more effective together than we would have ever been apart. And I think we spoke the mantra of high value care, which I think at least in Oakland we'll frequently distill to doing more with less. And I think we're both appreciating the benefits of an approach like this. A number of things. There's a lot of work to follow now, and I think we've got a wonderful platform to continue. We'll be looking at a very explicit cost analysis. We're looking at how this impacts our underrepresented patients. We do have very different populations, which Maud is going to talk a little bit about. As you may have heard, we did holidays in a lot of patients, including patients who weren't eligible for their data to be added to the database. And in our preliminary analysis, we're seeing very similar results. So the idea that if you're complicated, you have an underlying comorbidity that would have excluded you from the project, those patients seem to be responding very similarly. We're working on our sustainability efforts. And so again, a cross-Bay committee to kind of help move this along is going on. We do have some new wonderful, exciting data tools that I think are going to be very helpful. And in addition to continuing the holiday, which has been unanimously accepted by most groups on each side to continue doing, we'll be contemplating the initiation arm this winter. And then there's the ongoing collaboration. And I'm happy to report we did present our findings in the recent Health Improvement Symposium. There were a total of 196 posters. And again, I really want to celebrate the team effort that went into this. We were recognized as one of the 32 highest rated improvement initiatives during the symposium. We also received a Blue Ribbon Award for high value care, a distinction that only 18 of the posters received. So again, I'm just a wonderful way to top off the effort from a lot of different people. So our brief conclusion is that both campuses reduced the hours of high flow and overall length of stay significantly for patients with uncomplicated bronchiolitis without any adverse effects. And cumulatively, our two campuses surpassed the process and outcome measure goals of the project. And interestingly, these length of stay improvements may have helped close a gap for specific populations. And I'll let Maud close on that.
Yes, I want to talk to you about let me tell you about this new database, right? Because there's always one when you work at UCSF. So there's an enterprise-wide database that is the rabbit hole of all rabbit holes if you're interested in this kind of stuff. It's called CART Kids, and it allows us to look at length of stay from kind of a utilization standpoint against Children's Hospital Association standards. And this would give us an idea of sort of opportunity days. So an opportunity day is a day that you spend in the hospital that you maybe didn't need to spend in the hospital. And you can imagine for our populations what an opportunity day really means to a family. And so I took this database, which just came out 2 months ago, and just ran bronchiolitis patients through it during our baseline and intervention phases. And I just it's not project specific, but I want to show you some of the power of some of these analytic tools that we have. And so first of all, when we look at bronchiolitis, this is enterprise-wide across both campuses, right? And we look at our benchmark and our length of stay. So the black is the observed length of stay. We were generally at or above observed expected length of stay for patients with bronchiolitis. But then when we looked at the period of time during which we did our intervention, you can see that the observed length of stay is significantly below the benchmark, and that was consistent across both campuses. There were some other things that are really interesting that you can find out from these kind of databases now. So this is a tree map, and I could spend a lot of time explaining what that means, but it allows us to sort out when we're looking at length of stay based on different patient factors. And in this case, I used UCSF-derived race and ethnicity, which we all know is an imperfect measure, but it's what we have. And I was able to take the 77 patients that were diagnosed with bronchiolitis during this 3-month period and say who stayed longer and who stayed shorter. And there was a gap. The patients who are Latinx, which is 43% of our population, actually spent an extra 0.7 days, so had a 0.7 opportunity days in the hospital. So these patients spent an extra night in the hospital, but the patients who were white or Caucasian or Black spent a day less. And there's a clear difference in this population here. So that extra night in the hospital, we don't know exactly what we can attribute that to, because there was certainly a lot going on during this period of time during our baseline. But when we did our intervention and we started to really look at and standardize the care that we give to patients with bronchiolitis, and again, this is all bronchiolitics, now 209 patients, we'd see the same percentage of patients who are defined as, by UCSF, derived as Latinx. 44% of these patients are identified, but now they're getting out 0.7 days earlier. So really 1.4 days sooner than the baseline period. And again, this is a little bit of data dredging, but this is quality improvement, so we get to do that, right? But I can't say like this is definitely because of HIFLO, but I would say that when we provide, basically when we do common things uncommonly well, the people that benefit, this is how we can even out some of our gaps for our patients. And I wanted to just share about this database a little bit because it's new. And it would also allow us, when we're doing quality improvement and length of stay work, to start to really identify at-risk populations. And the people that are designing the database are very open to adding things in. So for instance, they put in the race and ethnicity at our request, and they are also going to put in language requirement at our request. So there'll be a lot that we can do with this database. So I really, again, want to just thank, first of all, everybody that came in person. It really actually makes a difference when you're giving a talk to have people in person. So thank you for coming. And I want to thank everyone who's listening on Zoom, particularly my mom. Hi, Mom. So Isla is, she's a retired nurse practitioner and an amazing human being. So I have to acknowledge that, and everyone else. And I know we're running very short, but I wanted to know if you have any questions.
I think breaking it down by race and the potential getting is really interesting. One of the questions that I had is how the families respond to the HIFLO holiday. And I have a bunch of kids right now in the teacup with bronchiolitis whose parents are extraordinarily anxious. And when we attempt to wean or do these holidays, which we're now doing frequently, and we're not go around study, I feel like the anxiety level goes up a lot. So I wonder if you have any thoughts about that and data, and also thinking about the different backgrounds of a lot of our families, if there is anything to be said of that, any kind of more of the qualitative data we might have.
Thank you, Efrat. I guess the question that she had, in case no one heard it, was how do families respond to this? And you're right, it's all very different. I think that when you start HIFLO, if you say part of this treatment is that we stop it twice a day and see how your kid's doing, and we're right there and we can put it right back on if they need it, is sometimes I think a way to sort of prepare them at the beginning for this. So they need to understand what it looks like to have HIFLO. And one of the things that I've also seen is that parents get very anxious when they're on 8 liters and they're on the maximum flow, and they're like, what do you mean? So I think that we need to sort of normalize and de-emphasize the life-saving properties of high flow nasal cannula. And that might also help with getting that kind of support and buy-in. I don't know if you.
Yeah, and a couple of other things would be that I think having a very clearly defined protocol, and we had lots of, we had handouts, and we actually had the holiday protocol attached to the HIFLO rig in the room. So I think it probably was some solace to families that we were actually following a fairly regimented strategy. Another really critical part about this project, and you probably saw it on the list of stakeholders. We had nursing, we had RT, we had residents, as well as the attending physicians in all of these units who were collaborating and speaking a common language and wearing our HIFLO stickers. But I think that also was really helpful because, as you guys know, a lot of the communication happening between the care team and the families is happening at the level of nursing and respiratory therapy. So I think everyone being able to say the same thing consistently was a real benefit.
Dr. June.
Great presentation, and I loved this project when it was happening, and still continue to suggest HIFLO holidays all the time in our very complex PICU bronchiolitis. I was wondering, we, at least on the SF side, have severe RT shortages, and staffing for RTs on our floor is very different than ICU. And I saw that it's, so you have to stand there and watch them and then come back. Were there any issues with that in the?
I will just speak directly to, so the question is with RT staffing challenges, which I think have on both sides of the bay, whether that this was a barrier, and sometimes it was. But there's also another point, which is an infant that's on high flow nasal cannula requires Q4-hour checks by the respiratory therapist. And an infant that's on low flow nasal cannula does not. So part of it is just getting an understanding that by investing that time, not only is it good care, but it also allows us to better utilize better make sense of what we're utilizing our respiratory therapists for. Because if an infant really doesn't need to be on high flow, then that therapist services are probably better off with other patients. So that I think was one of the arguments, and usually our respiratory therapists were actually some of the strongest proponents for doing these holidays, and a lot of times they would have done them before we even had the discussion.
Yeah, I totally agree, and in Oakland certainly we have plagued by the same issues with staffing, and I think I can't say enough what fantastic champions of this project the RTs as a group were, and the leadership, especially Irma Seabrook, who's the director of RT at Oakland, and David Woolsey on this side of the bay. They were excited about doing this project, and they were excited about improving care, and realistically, they were excited about saving some time. And I think that was a big factor. Any other questions?
What's your next thing you're gonna make better?
I think that we need to look at the high flow nasal cannula policies that are outside of the ICU across both systems, and really have a discussion about where in the hospitals it can be given. Does it need to be exclusively in the TCU? And also to set a weight-based sort of flow algorithms. The other thing is to really start looking at a lot of our protocols where we say, if the patient needs this setting, they have to go to the ICU, and change that to, if the patient needs this setting and they look like they need to go to the ICU, they should go. So we've taken a lot of clinical decision making out of the choices about who needs to be in the ICU. And it's having a huge impact not only on the ICU, but also on our patients. Because if you're in the ICU, more likely to get those ICU things that you might not have needed if you're just there because of a flow rate or BiPAP settings. So those are the kind of things that we would like to do. And I do want to sort of, like David Wiltsey and some of our respiratory therapy team and our nursing team are really trying to find ways to safely adjust the way that we look at patients instead of looking at the machines they're on, is to rather look at the state that they're in. So.
And also, I'll add that, you know, in the wake of the ICU collaboration, which has been there for a long time, you know, we now have unified divisions of hospitalists and emergency room physicians. And if we move on to the initiation phase, I think that collaboration is going to be really important. So, you know, initiation frequently happens in the emergency room. And so I think that's going to be a really great frontier for us to explore with this project.
I really just had more comments. Collaboration, teamwork can be very powerful and synergistic, and I think highlighting for everyone here and on Zoom these great opportunities for some of these networks to do and learn how to do QA many years ago. But I think you know, it's a great example of like really how, you know, we all kind of wrap our head around doing things better for our patients, and it's a great way to build bridges and collaboration. So congratulations.
Thank you.
Thank you. We're getting the hook from the back of the room. So